Alright you guys, welcome back to another video lesson from Rose Medical Lectures. This is gonna be the second part in our series on heart failure. In this lesson we are gonna be talking about the types of heart failure, and my name is Tania Rose Jacob. I'm gonna be the presenter for this lesson. Before we begin, if this is your first time to our channel and watching our video, please subscribe to our channel below and make sure that you hit the bell notification so that you will be notified as soon as our new video lesson become available to you guys. I really truly value your subscriptions, likes, comments that you guys leave. They really go a long way to help support the channel, and so far that I do wanna thank you guys. Okay, let's start. Basically, the heart failure can be divided into acute and chronic. We know by definition, acute means that occur rapidly and chronic means that occur gradually over time. But there are many cases of acute heart failure which develop from the worsened condition of chronic heart failure, or we can tell that in some cases acute heart failure can be caused by undiagnosed chronic heart failure. First, let's discuss about acute heart failure. Here, we are discussing some conditions that lead to the development of acute heart failure. We have a mnemonic here, acute very lean cardiac muscle. Actually, this mnemonic doesn't have much meaning, but for our convenience, let's consider this mnemonic. Acute stands for acute viral myocarditis and acute bacterial toxemia. Acute viral myocarditis means the inflammation of myocardium due to viral infection, and acute bacterial toxemia means the blood poisoning by bacterial toxic substances. And V stand for valve rupture. If the valve get ruptured, it can affect the one directional flow of blood, right? L stand for larger myocardial infarction, which occur when blood flow decreases or stops to a part of the heart, causing damage to the heart muscle. And C stand for cardiac tamponade, also known as pericardial tamponade, is when there is a fluid buildup in the pericardium resulting in the compression of heart. M stand for massive pulmonary embolism. Pulmonary embolism is a blockage in one of the pulmonary arteries in your lungs. In most cases, pulmonary embolism is caused by blood clot that travel to the lung from deep veins in the leg, or rarely from the veins in the other part of the body, also known as deep vein thrombosis. Because of these conditions, there will be sudden reduction in cardiac output, which leads to the systemic hypertension. There will be no edema in acute heart failure, but there is a state of cardiogenic shock, means a condition in which your heart suddenly cannot pump enough blood to meet your body's demand. In acute heart failure, cerebral hypoxia also develops. That is, the brain is not getting enough oxygen. It's about the acute heart failure. Here, remember the mnemonic acute very lean cardiac muscle. Next, let's move on to the chronic heart failure. More often, the heart failure develops slowly in the following state. First one, myocardial ischemia from atherosclerotic coronary artery disease. That's because of the buildup of plaque inside the artery. The artery becomes narrower and slows down the flow of blood. Because of this atherosclerotic coronary artery disease, the blood flow to the heart is reduced, which prevents the heart muscle from receiving enough oxygen, resulting in the myocardial ischemia, which in turn lead to decreased cardiac output and heart failure. The second one is multivalvular heart disease. That is, any damage to the heart valve can affect one directional flow of blood and decreases the cardiac output and gradually can lead to heart failure. Third one is systemic arterial hypertension. That is, high blood pressure in the systemic arteries. That means the high blood pressure in the vessel that carry blood from the heart to the body's tissues other than the lungs. Because of this high pressure, the heart has to pump hard to eject blood from left ventricle, thereby increases the mechanical workload of the heart. In etiology, we already discussed that increase in the workload can lead to heart failure. The fourth one is chronic lung diseases resulting in the hypoxia and pulmonary arterial hypertension. Here, lung diseases can affect the oxygenation of blood and cause hypoxia. Hypoxia means the absence of enough oxygen in the tissues. Pulmonary artery hypertension means high BP in the arteries that go from your heart to your lung. Because of Because of this high pressure, the heart has to work harder to pump blood from the heart to the lung for oxygenation, which eventually lead to heart failure. In chronic heart failure, many compensatory mechanisms like tachycardia and cardiac dilation and cardiac hypertrophy take place. We will discuss about this in another video. So here, now we discussed about acute heart failure. There we learn one mnemonic. After that, we discussed some conditions that can lead to chronic heart failure. Actually, there is systolic heart failure and diastolic heart failure. Next, let's discuss about that. Systolic heart failure can occur when the heart cannot pump enough blood. Diastolic heart failure occur when the heart cannot fill enough blood into the ventricle during diastole, called diastolic heart failure. First, let's discuss about systolic heart failure in detail. It's a condition when heart cannot pump out enough blood. We know heart squeeze out certain volume of blood each minute called as cardiac output. By equation, the cardiac output is equal to the heart rate into stroke volume. From the equation, it's clear that the cardiac output is influenced by heart rate and stroke volume. According to the equation, if any of these two increases, the cardiac output can increase. So there are some factors that influence the stroke volume. These are the preload. When the preload increases, the stroke volume also increases. Second one is contractility. That is, when the contractility increases, stroke volume also increases. The third one is afterload. When the afterload increases, the stroke volume decreases. Here, inverse relation. Afterload is inversely proportional to stroke volume. And we already discussed cardiac output is equal to heart rate into stroke volume, where heart rate is the number of beat per minute, stroke volume is the volume of blood squeezed out with each heartbeat. In normal condition, we know usually we will tell the values in a range of numbers, right? Example, the heart rate is between 60 to 100. Normal heart rate is between 60 to 100 beats per minute. But here, for the convenience of calculation, let's take heart rate as 70 beats per minute and stroke volume as 70 milliliter per minute. So the cardiac output is 70 into 70, that is equal to 4900 milliliter per minute. That is approximately 5 liter per minute. The whole blood in the left ventricle will not eject to the aorta. If the total volume of blood in the left ventricle is 120 milliliter, about 70 milliliter of blood is ejected out with each beat, and 40 milliliter is remaining in the left ventricle. Here, the ejection fraction is, we have a equation here. Ejection fraction is equal to stroke volume divided by end diastolic volume, which is equal to 70 milliliter divided by 120 milliliter, which is equal to about 58%. Normal ejection fraction is between 50 to 70%, whereas 40 to 50% is considered as borderline. And if the ejection fraction is less than 40%, we consider it as systolic heart failure. That is, very little blood is squeezing out of the heart. It's about systolic heart failure. Next, let's discuss about diastolic heart failure. Diastolic heart failure means the left ventricle is not able to fill properly during diastolic phase, which in turn reduces the amount of blood pumped out of the body. So less filled means less ejected. Here both are lower, but still sometimes your ejection fraction can be the same as a healthy heart, that is 58% as per our calculation before. And we would call that a preserved ejection fraction. Okay, that it seems a little confusing, right? Let's see one example. We have the equation ejection fraction is equal to stroke volume divided by end diastolic volume. Say your stroke volume is lower because of heart failure. Say it is 46 milliliter instead of 70 milliliter, and your end diastolic volume is also lower. It's 80 milliliter instead of 120 milliliter. So the ejection fraction is equal to 46 divided by 80, which is equal to 58%. Still 58%. That means technically in a normal range, but it's a heart failure actually. So clearly the stroke volume and blood being pumped out is lower here, but that's being covered up by your end diastolic volume being lower too. Even if it has normal ejection fraction, it's a heart failure because here ejection fraction is preserved but the stroke volume is less. That is, the blood pumped from your left ventricle per beat is less. Let's see some conditions that can lead to diastolic heart failure. First one, hypertrophic cardiomyopathy. Here the heart muscle grow thicker than usual, leaving less space for blood filling. Second one is restrictive cardiomyopathy. Here the heart muscle become rigid, unable to stretch and affect the filling of left ventricle. And third one is hypertension that can also cause diastolic dysfunction indirectly via compensation mechanism. That is, during systemic hypertension, it is more difficult for the ventricle to pump, so how the heart compensates it is by growing thicker muscle to try harder. Thicker muscle means reduced space for blood filling. Next, let's move on to the left-sided and right-sided heart failure. The things that you are gonna see here be the result of same thing that you would see for both left and right-sided heart failure, because these two systems really works in a series. When you have one side that fails, that can lead to the failure on the other side. Sometimes you can end up with the biventricular heart failure. First, let's see about left-sided heart failure. 2/3 of all the cases of left-sided heart failure are gonna be result of systolic heart failure. Here you can see the backup of blood to the pulmonary circulation. Because of this, the extra blood you are gonna have increase in the pulmonary artery pressure and fluid shifting to the interstitial space, something we called as pulmonary edema, and result in the congestion of the lung, from where the term congestive heart failure derived. The causes of left-sided heart failure is due to the diseases impacting the left side of the heart, like coronary artery disease, cardiomyopathies, and valvular diseases. Valvular diseases, specifically aortic stenosis or mitral regurgitation, since aortic valve and mitral valve are on the left side. We come to when we come to signs and symptoms, there will be increased pulmonary arterial pressure, pulmonary edema, and crackle on auscultation. Dyspnea means the shortness of breath. Orthopnea means sensation of breathlessness in the recumbent position. Other than the symptom, due to the backing up of blood, there are some symptoms which appear as a result of blood not moving forward. As a result of that, the patient may be fatigued and become lethargic, weak. You can also see decreased urine output. Decreased ventricular output causing the hypoperfusion and diminished oxygenation of tissues. In kidney, hypoperfusion results in the ischemic acute tubular necrosis. In brain, hypoxic encephalopathy. In skeletal muscle, muscular weakness and fatigue. Next, let's discuss about the right-sided heart failure, commonly caused by the left-sided heart failure. Let's see how it comes. This is because the increased pulmonary pressure caused by the left-sided heart failure make it harder for the right ventricle to pump into the pulmonary artery. This results in the systolic dysfunction. In compensation, the right ventricle grows thicker to pump harder, which reduces the space available for filling, eventually leading to diastolic dysfunction. In case of right-sided heart failure, we now have the failure of right side, right? So again, if you think about it, we know the function of right ventricle is to pump blood to the lung for oxygenation. In case of right-sided heart failure, we are not going to be moving the blood enough forward, therefore result in the backup into the systemic circulation, that is increase in the pressure in the system before the right side, which is going to be a increase in central venous pressure, end up with the fluid shift resulting in the peripheral edema. So other than this, you can have some isolated causes like left to right hand shunt, like atrial septal defects or ventricular septal defect. Because of this defect, the blood shift from the high pressure left side to the low pressure right side, resulting in the increased blood volume on the right side, which result in the concentric hypertrophy. Another isolated cause is the patient having chronic lung disease. Because of the lung disease, the patient become hypoxic, finally result in the cor pulmonale. The signs and symptoms of right-sided heart failure. First one, elevated central venous pressure. Jugular venous distension. Peripheral edema, most likely to see this in feet when standing and sacral area when lying down. The fluid status can be assessed by examining the distension level of the jugular vein. We already told that. Then next one is next signs and symptom is hepatosplenomegaly. Due to the fluid backing up to the liver and spleen, resulting in the failure of the liver. These are fluid. The signs and symptoms due to the enough blood is not moving forward include fatigue, weakness, lethargy, and decreased cardiac output. In left-sided heart failure, we discussed that the patient have decreased urine output. But in right-sided heart failure, the patient have increased urine output at night, because at night when they lay down, fluid shift from peripheral areas and feet and reabsorbed by the body, resulting in the increased urine output as the body tries to get rid of this excess fluid. So, right-sided heart failure can cause pathologic changes like ascites, that is the accumulation of fluid in the peritoneal cavity, causing the abdominal swelling, hydrothorax, congestion of leg veins and neck veins, reduced cardiac output resulting in circulatory stagnation causing anoxia. That is, anoxia means severe hypoxia or an absence or deficiency of oxygen reaching the tissues. Cyanosis means the bluish discoloration of the skin due to poor circulation or inadequate oxygenation of the blood, and coldness of the extremities. In summary, in early stage of left heart failure, manifest with the features of pulmonary congestion and decreased left ventricular output, while the right heart failure present with systemic venous congestion and involvement of liver and spleen. Chronic heart failure, however, combines the features of both left and right heart failure. It's about left and right-sided heart failure. Next, let's discuss about the backward and forward heart failure. First, let's see what's backward heart failure. If either ventricle fails to eject blood normally, there will be a rise of end-diastolic volume in the ventricle, which result in the increase in pressure and volume in the atrium. So due to the more volume in the atrium, it get transmitted backward, producing elevated pressure in the veins. Next, let's see forward heart failure. According to this hypothesis, we already discussed that the heart failure is the inability of our heart to pump enough blood, right? As a result of this, there will be diminished flow of blood to the tissues, especially diminished renal perfusion and activation of renin-angiotensin-aldosterone system. It's about today's video. Thank you so much friends for watching. I hope this helpful for you guys. Please leave a like, drop a comment. Above all these things, subscribe my channel and hit the bell icon so that you will notify when I am uploading new video. Thank you so much. Bye. Take care.